Thanks to all who are online for joining us today. We have a full schedule, so I'm going to turn this directly over to Jim for the roll call.
Good morning. Thank you. With that, I'll start out with the co-chairs. Claudia Cohn.
Present.
Diane Wilson.
Present.
Next, I'll address the public members. If you're present, just indicate that you're present. Beer Andy Miriam. Moving on to Ray Goodrich.
Present.
Jed Gorlin.
Present.
Sally Cagliotti.
Here.
Elisa Gordon.
Present.
Cassandra Josephson.
Present.
Michelle Kamika.
Present.
Daryl Kaur.
Present.
David Perez. Moving on to Jim McPherson.
Present.
Paul Ness. Next, I'll have the roll call for the representative members. Lynn Ewell.
Present.
Gary Markland. Lou Barnes.
Present.
Benny Yang.
Present.
Eric Santiago Justiano. Moving on to Susan Galil.
Present.
Next, I'll do the roll call for the ex officio members. Sridhar Basaraju.
Present.
Scott Brubaker.
Present.
Nicole Verdun.
Present.
Marilyn Levy.
Present.
David Stronach.
Present.
Diane Corning.
Present.
Thank you. With that, we do have a quorum. The meeting can officially begin.
Thank you, Jim, and thanks again to everyone. I want to take this opportunity to give an extra thank you again to the HHS staff that brought this meeting together, Jim Berger, Lauren Overman, Allison Pedkoff, and Sarah Parker. I also would like to call out the Rosalie Associate staff who make it all easy. Christine Duchley, Stephanie Tilner, thank you, and Megan Walsh, thank you. So thanks to all. Today we have a full schedule where we're going to hear about many of the activities that are going on within as a result of the ACB-TSA work, and sometimes things that are simply tangential to the ACB-TSA. These include the Alloantibody Exchange Program, the US CDI and ONC Health IT Certification Program, updates from the Tissue Biovigilance Subcommittee, and an update on the Giving Equal Living campaign, and finally, methods to extend the outdated blood bags. After those presentations, we will turn to a review of the recommendations and try to vote a few more through today. One last thing, and that is a note on the usefulness of the ACB-TSA. It is easy for me to fall into cynicism and see the difficulty in getting various recommendations through and seeing the end game, seeing the results of those recommendations. But I think we all have to hold on to the successes because that will keep us going, keep us working. We are seeing the alloantibody exchange. It may be implemented. The HOPE Act, which was HIV positive organs for HIV positive patients, is a huge positive force that has gone through the ACB-TSA. Jim?
Yeah, certainly with that, because of the ACB-TSA, we did do the RAND study. It was a study that was needed to get the data. And just like some of the recommendations we're talking about, we can put those recommendations and then we can move them forward. I, along with Claudia, would like to think that with the great recommendations that were put in the report to Congress, that Congress would enact on them. The urgency sometimes that I have for those recommendations is not also met with those that are reviewing them. And so I just hope that it's laying the foundation, and it does give an opportunity with the public-private partnership. Because of some of those recommendations, ABC, ARC, BCA have all jumped in and supported them and moved those forward. We definitely have a champion with Admiral Levine. We've never had such an advocate before. She takes the blood safety office responsibility seriously. She now meets as the chair of the Blood Organ and Tissue Senior Executive Council. She looks at those recommendations. She brings in the federal partners to see what the other agencies can do. And this is something that is not just an OASH responsibility, but it's also our other federal partners, CDC, HRSA, NIH, all the other partners have an opportunity to buy into them. ASPR, BARDA, I mean, I don't want to, CMS certainly, they all play a role. The other thing that came up was the tissue tracking that we had a meeting a couple of years ago. We came up with some serious recommendations to move forward, and we're continuing to work on that. Tim Pruitt and Scott Brubaker are chairing that working group, and we're not letting that issue of the tissue tracking remain unsettled. And Admiral Levine did ask for a report, and we're going to provide that to her. So that's just an example of, even though it might seem like all our recommendations aren't carried out, they're still there, and we still want to do that as much as we can.
Thank you, Jim, and thanks again to everyone. So with that, let's move on to Christina Duchley and the alloantibody exchange presentation.
All right, thank you for the introduction. So I'm going to be presenting on behalf of Rosalie Associates and our work on the red blood cell antibody patient data exchange with OIDP. So just to start with a little background on why we started this project. As you all know, there's a lack of a US-wide RBC antibody data exchange, and it puts transfused patients at risk. We're really dealing with a fragmented system when it comes to accessing this patient data history. And there's only one national-wide registry that currently exists. So there's not a lot of source information on the process knowledge of how you get something like this set up. Multiple barriers have been identified, but not yet systematically investigated. So we look to do a formal environmental scan to inform the strategic planning process towards the establishment of a national patient data exchange. Some additional background, blood disorders like sickle cell disease and thalassemia and complications during childbirth, as you know, disproportionately impact populations that are historically underserved in the US. And because of this, this RBC antibody patient data exchange project has been chosen for development as part of the HHS Secretary's Challenge of Equity Award. It's a part of 24 innovative projects that were selected to advance equity in programs, policies, and processes across the agency. Okay, sorry, clicker's funky. All right, so this slide just lays out the different phases to our current projects that I'll break down a little bit further in a few minutes. Note here that we have a few important data sources that we included in our final report. We looked at literature, we established a RBC antibody working group, and we also conducted stakeholder and subject matter expert interviews. So to start with the scoping review, we initially started by diving into the literature, both national and international, and published and unpublished, looking at topics including information related to existing exchanges or registries and data health systems, with particular attention to the implementation process and sustainability of systems. But when we first started looking at the literature with our rapid scoping review, really limited published literature information came up about these processes, specific to health information exchanges and, of course, RBC antibody exchanges specifically. So we weren't able to report out a traditional literature review, which was what we started with wanting to do. So instead, we developed case studies of current or previous systems that were identified through subject matter experts or during the literature review. So like I mentioned before, we developed the RBC alloantibody exchange working group. With OIDP, we identified relevant subject matter experts and representatives of impacted patients. And this slide just lists out all our different member representation for this working group. We held bi-weekly meetings where some of these working group members presented, and we also had people who were subject matter experts outside of the working group present as well to inform the project. So this is just an inclusive list of all the working group presentations that we held. We still have one last working group meeting where we'll hear from the Department of Veterans Affairs and Department of Defense. So the main part of my presentation today is going to be reviewing highlights and key takeaways from the case studies that are included in our final report. I'm going to look at established national systems, established regional systems, and a couple attempted regional systems. I want to note that a couple of the case studies do focus on the exchange of antibody data specifically, but because there's limited information on this, we also look at the exchange of general health data records that can be applied to understanding system implementation. So here I've just laid out a list of the stakeholder interviews that we conducted to inform our final report. This was outside of the working group. And these stakeholders were identified during our review of the literature and helped bolster the final report. So now to go into the details of the case studies, the transfusion register of irregular antibodies and cross X-match problems, or TRICS, as many of you know, is the only national RBC antibody system to currently operate. It covers nearly all of the hospital laboratories in the Netherlands that would need to access this. And I've listed several details about this case study, but the major takeaways are that we know that the Netherlands registry supports a much smaller number of patients than a US exchange or registry would need to, but it does provide several important lessons that I've highlighted here. The factors that we think really contributed to its success include the sustained funding that it has, the stakeholder engagement, and the ownership and leadership from a reputable established organization. And they also incorporated the use of this register into their blood transfusion guideline, which we think was an important part to its success. Next, I'm going to cover the European Union eHealth digital service infrastructure. They are also called My Health at EU. So this isn't going to be specific to RBC patient data, but it's important because it provides cross-border access to patient information across the European Union, and they're looking to expand to all EU member states by 2025. This project it began in 2008 with a pilot, and throughout this time, it did see barriers, especially between the pilot and implementation phases. They experienced slower than expected expansion, but their expansion efforts continue. They do have several elements to success, including funding from both the government and industry partners. And they had a long, well-established pilot phase that developed the systems that they're currently using. They're also currently making attempts to address the barriers that have come up, including a proposal to shift from voluntary to mandatory participation in this system. Another national EHR system, again, not specific to RBC data, is the Canada Health Infoway system. Infoway serves here as a coordinating center that provides the standards to facilitate the goal of a system that's nationally interoperable. They have experienced some barriers to cross-border interoperability, as you can imagine, but they continue to operate nationally and continue to reach areas that aren't currently covered. They've had a lot of stakeholder engagement, which was critical to the success of this. And this case study really demonstrates the importance of iterative evaluation, where as barriers and criticisms came up, they worked to address them. And I think really importantly, provided guidance to the jurisdictions that were implementing the system. Now I'm going to transition to a couple of regional case studies. Of course, we're going to talk about the Kansas City Antibody Registry. It was launched in 2008 as a service area-wide registry to link patients and antibodies detected at community blood centers immunohematology reference laboratory. This is a successful registry that continues to operate despite a shift in ownership. And we think some of the factors that contribute to its success include consistent leadership of a reputable organization, sustained funding, and stakeholder engagement. They do rely on manual procedures that likely limit its scalability, but we see a really positive indication here that the involvement of credible stakeholders affect participation and registry's reputation. I'm also going to touch on the Wisconsin Statewide Health Information Network. This started in Wisconsin, but has expanded to neighboring states, where they're currently covering 2,100 client sites. They've had funding initiatives that have helped improve participation in this, so we think that's a really important element to this. They have encouraging cross-border reach. It's especially encouraging to the development of interoperability. Despite differing data privacy laws in other states, it will probably continue to remain a barrier to expansion. We can see that it's not impossible to do so. And finally, I'm going to cover 2 final case studies where we're going to talk about lessons learned. The first one being the Georgia Pilot Red Blood Cell Antibody Exchange, which was an attempted pilot program that began in 2015 with 2 university hospitals and a major health system in the metro Atlanta area. They started with a CDC grant to test the feasibility and expand to other Georgia health systems. And this grant was implemented to study transfusion-related complications in patients with sickle cell disease and thalassemia. So importantly here, although the pilot didn't end up reaching its initial goal of full implementation, they saw really strong physician and administrator support. It took a lot of people doing a lot of hard groundwork to do this. So we can see that it's something that's really important to people. Their major barrier was, unfortunately, the lack of IT support. There was an issue with security safeguards and concern of taking on that risk. But knowing this barrier can help plan for it in the future. And the final case study I'm going to touch on is the Santa Barbara County Care Data Exchange. This was an HIE project designed to connect 3 hospital health information systems in Santa Barbara. They started in 1998, but ended up shutting down in 2006 after a brief implementation period. So what we learned here is that when the momentum in a project is disrupted, it can ultimately cause major issues. They had a lot of promise in the beginning stages, but they had slow technology development and also a company transition that resulted in the lack of sustained implementation. So we think that this shows that proper implementation planning, especially readiness assessments, are really critical to the success of this type of system implementation. So to start wrapping things up, of course, I didn't have time to go really into the details of all the case studies and the many things that we learned from this, but we have been able to really, I think, compile a document that can be referenced to understand all the different barriers and facilitators to success that can really help with future efforts. So I've listed some of the common barriers that are seen over and over again in these case studies. These include lack of implementation planning, legislative interoperability, differing adoption of standards, and others. And we also see a lot of different elements to success that we should consider, such as sufficient long-term funding, high stakeholder buy-in, streamlined system structures that are easy to use, and others. All right, so to finish wrapping up here, we know that the benefits of establishing a national red blood cell antibody data exchange are clear. These include improved health outcomes, especially for people in underserved communities. It could also serve as a clinical research data set for understanding, for example, information about evidence antibodies, further information about sickle cell disease and thalassemia and others. It also could really serve as a source of patient education and empowerment. We've seen that there, through the study of other health information registers and exchanges, that there are many obstacles to establishing something with such wide coverage, but we've also seen through several examples that it is possible. We did leave with a few unanswered questions. Some of these include, how will nationwide interoperability be established? What data should be included in an exchange like this? This is really important to make sure it's fully useful to those who are using it. What procedures do you need to ensure and verify data accuracy, especially so that providers have confidence in using data inside and outside of their hospital? What steps are needed to overcome user resistance and hesitancy so that you can ensure participation in an exchange? And also, how do you achieve cooperation among competing entities in this space? Finally, we want to know how the government and professional societies can strategically promote the use of a national exchange through guidelines and recommendations. So we're going to look at these and other questions in the next phase of the project. So we're currently in phase 1, and the first box I covered today was all information going into our final report for this first phase. And then in the second box, which will be the next phase, we'll be looking at continue work with the RBC working group to do future work on identifying pilot options. And we'll use all this information that I talked about today in our final report to help with that second box there. This lists some more detail on our next steps, but we're hoping to move to the next project phase in the fall, where we will continue to work with the established RBC working group and continue collecting data to inform the exploration of pilot options. And lastly, I wanted to bring it back to the patient impact to end this presentation. This is really what the project is all about, is helping patients receive safer treatment. In our final report, we have a couple patient profiles, which I've pulled here. These are from those that were on our working group. One of our patients talked about how she saw the need for patient education in sickle cell disease patients and how antibodies can affect their treatment. And they really thought that a national data exchange could help address this. Another patient who has thalassemia, who has a strong passion for travel, talked about how thalassemia has really impacted his ability to travel. And a national data exchange would help give him a new peace of mind when he's away from the home transfusion center that he trusts. And that's all.
Thank you. Are there questions from the room? Ray.
You gave several examples, and I think the spread on the financial aspects of setting those systems up ranged everywhere from $24,000 plus an administrator salary up to $10 million over a 3-year period.
Yeah.
And I'm wondering one of those systems seems to be sustainable, the lower cost one, because it's still ongoing. And one example at the $10 million, I think, had to shut down.
Right.
So we're both providing what was needed. And is there an example or some information that can be gathered from that in terms of what's affordable and what's sustainable?
Yeah, that's a great point. So I'll mention that the one that was a little less that you talked about, one of the things that's actually keeping them from maybe expanding more, it's very manual based. So all this different, I think it's a very careful play of elements. You could spend more money and it could still fail, and you could spend less, but now it's not as expandable. So you have to consider all those different factors, which is, of course, it's not an easy answer.
The founder of the KC Registry is in the room, Jay Menitov, and he is very excited that the paper reviewing the 10-year experience was accepted to transfusion last week. So you'll read more about it when you know all about it. I will say it is not lost upon me that the success of the Sanguine system is that they have a national healthcare system and a national blood system, and it makes it a lot easier.
Yes, that's a great point. And yeah, there's a lot of differences when it comes to our system and the Netherlands. Unfortunately, it's not that simple.
Cassandra?
Yeah, I just wanted to say, so we were one of those failures up there, the one that we tried with the CDC And it had to do with IT. It wasn't about money, and it had to do with hospital buy and liability. And so some of the things when we were doing it that early in 2015, some of those barriers are a little bit better now because Epic and other electronic medical records are letting patients come into the portal and all the rules of sharing data with patients. Because part of it is believability, being able to prove that your antibodies are the antibodies that you have and carrying that around with you and having some agency as a patient. So I think the money question each day gets less expensive from the parts that have to do with the sharing of information. And it's more about the obstacle of what, Jed kind of alluded to, that we don't have a national system. But even if we still don't have a national system, which I'm not sure we're going to fix that problem because that's a very big problem. But there are other ways now, I think, at this moment to be able to connect the dots and learn from, what Jay put into place and being able to do that. So I'm optimistic that, in this time, we have all the pieces. It's just a matter of who's the glue that runs it together. And I believe it's the government that is the glue, kind of helping us make those connections. But I don't think it's expensive. It's $10 million anymore. At least that's my opinion.
Yeah. Thank you.
Any other questions in the room? If not, then I have a question.
Yes.
This current initiative began with the Yale group developing software by George Hauser.
Yes.
And trying to put that software into the LIS systems. Their logic was there are only about 9 major LIS systems that cover all of the U.S. If we could just get to some of those, we have the beginning of an exchange. They got a contract with one. It needs to go through the FDA still. I believe that they were on the verge of getting a second. And they recently had a GoFundMe sort of effort because they are desperately in need of funds to keep things going. I'm just wondering how this effort and their effort can dovetail, whether it is thought that the issues Cassandra brought up about hospitals trusting, opening their data will so affect their model and the LIS model that it wouldn't work in people's opinion, or whether this is a potential model in your opinion.
Yeah, that's a great question. So I can't fully answer, how it will move forward with other organizations. I can say we've had George on our working group and he's been a really important part of it. And that work is absolutely foundational also to incorporating into this project.
Are there any people online who would like to ask a question? I see a comment from Daryl Kaur. I could just read the comment, or Daryl, do you want to come on and speak?
Sure, happy to. I'm just wondering if there's a role potentially, because we do have such a limited number of EHR vendors at this point that cover most of the United States, if there's a role the vendors could play in helping to accomplish these goals.
Yeah, absolutely. That's a big part of moving forward, is working with all those different parties that could potentially have a role in that. And absolutely, EHR vendors would be a part of that.
Paul Ness?
Yeah, is the assumption that the data would be put in by hospitals or blood centers or both?
Yeah, that's a fantastic question. And I'm going to keep saying this, but it's also a part of future work, is identifying that and identifying, a pilot option that shows how exactly that works. We don't know yet.
Cassandra.
So I just wanted to, say, what Paul's bringing up is very, very important, but I think we're moving to a place where the common model, data entry, and things are like, that's what I was saying, coming to a place. NHLBI sponsors the REDS 4P vein-to-vein database, and they're working with that modeling of bringing things in, like with the common, standardized language, and NHLBI through REDS has built the language for transfusion to be standardized in that vein-to-vein. That could be an element of how we learn to tie things together from the LIS system and into the electronic medical record, because that is what is tied together in this vein to vein. So I think some of these pieces are kind of all over that everybody's talking about, but to make this, more generalizable and not as manual as where Jay is at is really where we need to be. So, because in real time, when people have those antibodies identified, people need to be able to see in and know that that's the next antibody. That's part of our problem lagging behind. So maybe I didn't know on the working groups if, do you have representation from like Epic and from maybe, from Columbia, who has like the OMOP modeling and.
Yeah, so we don't have that representation yet, but identifying those key people who we need to keep working with, we'll absolutely keep doing that work. Yeah.
Thank you very much for the hard work.
Thank you. Any other questions?
Can I ask this, Daryl Core, can I ask just one more real quick?
Please, Daryl.
One of the issues that we've run into here at Mayo, because we have multiple sites and multiple labs, is that, for example, we might have testing done at one of our community hospitals, but then when that patient gets transferred for an advanced level of care from the community hospital to our academic environment, for example, in Rochester, my understanding was that I thought it were CAP regulations that you had to have a new type and screen at that new facility to be able to use the results of the type and screen testing to determine antibody status. So one of the problems, I think, is the hospitals aren't finding a great deal of value necessarily in getting the information from other locations because they just have to retest to determine the antibody status of that patient at their facility. And I don't know if I just misinterpreted that challenge that we had, or if that's in fact real, and maybe that's something that could be addressed as well.
Well, Daryl, it's Cassandra. So some of what you're saying is absolutely on target, but one thing that is important from the other is the historical antibody part, and they have an essence of antibodies. So even though there's a type and screen, they're not. That might not be the entire antibody profile and what they need to match for and be antigen negative for, and that's actually where this falls apart. So the need to be able to know the historical pieces is what the one of the critical pieces.
Okay, thank you. And thanks again. We're going to bring up Dr. Albert Taylor next, who is going to give us an update on the USCDI and ONC Health IT certification program. Dr. Taylor?
Good morning. My name is Al Taylor. I'm a medical informatics officer in the Office of National Coordinator, right across the street, or Caddy Corner. I was a OBGYN in the Army before I became a clinical informaticist, and I've been working at ONC in the standard space for the last 8 years. Next slide. Next slide. So I'm here to talk about USCDI and other aspects of the ONC certification program and how it may apply and be helpful to all of your efforts. Next slide. USCDI is, we define USCDI as a core set. So the C is core, D is data, the I is interoperability, right? So this is what we have identified as the set of information that ought to be available in an EHR and for exchange, especially for exchange, and so that everybody who is looking for data knows what they're getting when they get the set of data from another source, or if they're looking into a record, what they should be expected to see and be able to download. As a standard, as a government developed standard, it also serves as a baseline, just as a baseline set of data. For other uses. So the primary use case for USCDI is patient care and patient access to their data, but other systems, other reporting programs may also use USCDI as that core set. It might be modified, it might be, or it might be less than what's in USCDI. And we've also established a process to expand it over time to respond to different needs, different policy priorities, and other purposes. Next slide. USCDI was developed, was first published in 2020 in response to our Cures Act final rule, which is a certification rule, and the these bullets indicate the specific areas within our certification program where USCI is required. There's two parts of it that's most important to focus on. One is the use of FHIR, FHIR application programming interfaces to access data that is part of USCDI, and the content within the consolidated clinical data architecture documents, such as transitions of care documents, patient view, download, and transmit data, which was mentioned earlier about a patient can not only view their data, but also send it to someone else, potentially another provider. And then some other uses of the CDA documents, along with just another aspect of accessing data from the outside through APIs. Next slide. So this is the first version of USCDI. In addition to the common clinical data set, which was its foundation, it added several aspects, including clinical notes and provenance, both of which are important, and some other data elements. Next part. We also, in an effort to address equity concerns, over the next two versions, we added several equity-based components, including SOGI and SDOH. Next slide. We expanded in USCI version 3 to address additional equity and disparity issues, along with expanding into the public health reporting space. And this is just a quick note about USCDI version 3, which is already out, and it has been noted in our recent proposed rule as the new standard, as sort of an update or an upgrade from version 1. And next slide. In January, we published draft USCDI version 4, which added a number of different data elements, including several health status assessments and some other data related to patient preferences and medication use. Next slide. We, as the public submits recommendations for additional data elements, and they can come from anywhere, and they do come from anywhere, we have to sort amongst those recommendations for new data according to some technical priorities and some policy priorities, and these are listed here. Next slide. With USCDI already has a number of data elements that are required parts of the data set, and these are listed here. The last 6 with asterisk are ones that are part of the draft USCDI v4. We hope to publish v4 in actually this month, and so those if adopted would become part of the record. But I wanted to focus on the first one, which is the test. So lab test includes a lot of different tests. These include and they include things like antibody testing, antigen testing, and these are what it means to have a lab test data element in USCDI with the standard using LOINC is that all certified EHRs or other health IT have to be able to represent a lab test using LOINC, and that means that when they exchange the data on lab test data and lab result data, they have to at least identify the test that was performed and give the result at a minimum using the SNOMED code vocabulary set. And so this is already something that's in place, and it's been in place for all of the USCDI and even going back into the common clinical data set. So what this means is that there is an established system that is almost universally applied in hospital settings to be able to capture and exchange lab data using LOINC codes. So that is, I send you a LOINC code, you have a certified EHR, you get my LOINC code, you understand what that LOINC code means. And accessing those data through the APIs, that's an opportunity to query an EHR for particular lab data, such as the tissue data, the antigen and antibody testing data that is available in that EHR. that obviously assumes that the data is coming in with high fidelity from the LASs, which is a separate issue. But the lab data that does come in is getting is in most cases being natively stored as low-ink codes and then transmitted in low-ink codes through exchange. So those are some things that are already in place with this program. Through the expansion process, we have received other recommendations for new data elements. Next slide. Including the several data elements related to human tissue, biologically derived products. These were submitted by the FDA. There's an established standard to identify individual units of human tissue, and using an established standard ISPT 128. We have not adopted that into US CDI as of yet, but it still remains as a standard to be used. It can be implemented in EHRs, but it's not a requirement as part of US CDI or other certification criteria. Next slide. Other certification criteria that support labs include computerized order entry, the clinical quality measures that identify that have as their value sets lab data. I mentioned view, download, and transmit. This is not only viewing but downloading as a CDA document, patient data that can be then exchanged or provided to other parties, and then several public health reporting messaging criteria as well. All of these potentially can support the exchange, the collection and exchange of various lab data, and it's just offered up as another thing that certified EHRs do and can do. Next slide. In some cases, in many cases, the needs of a particular program exceed that of what US CDI can do, because again, US CDI is US core, not necessarily addressing every single data use case. And so what ONC has developed over the last 2 years is a program to identify other data needs for specific programs. We currently have up and running US CDI Plus quality and US CDI Plus public health, and we're expanding into other areas that are noted here. This is another way to identify data that's needed for exchange, and it also is sort of user driven or program driven. We coordinate with a number of different federal agencies already to work through these programs. Next slide. And the final one I wanted to mention is what ONC is involved with, and actually we've been doing this for also about 8 years. ONC has an interoperability standards advisory, and what that is really a compendium of data for a wide variety of data uses or interoperability needs, including terminology for the content, the payload, the structure of documents, and other combinations of data, the ability to exchange, the methods, and the ability to exchange data, and then a variety of different administrative functions. This is a very flexible system that can be used. It is being used to identify data standards that aren't necessarily regulatory. We do make note where some of these data are required in federal programs, including certification, in the MIPS program or other programs. And users, it's very easy for a user to identify the content and get it added as a page, even though it's not regulatory, not regulated, or not required. It stands there as a reference for what's out there, so everybody can come and look and see, like, we agree with this, we think it should be changed, we think it should be expanded, we think it should be required. The ISA is a great place to go to look for stuff or to put stuff that can be used to identify these data needs. Next slide. And that is it. I'm happy to take any questions. So that was a whirlwind tour of the ONC certification program. I'm happy to answer any questions.
Thank you. That was really interesting. Cassandra.
That was great. I have a question about how your office puts pressure, able to change or sort of look at what the standards are that you have EHRs or laboratory information systems they have to comply. Like, how does it transition with what you're saying to what has to be done?
Okay.
Yeah.
Yeah, sure. Happy to answer that. So what it means to have the ONC certification program has certain criteria. I mentioned that on one of the slides. USCDI is a certification criteria, and if an EHR, the EHR certification program or the ONC certification program is a voluntary program, it's required to report to Medicare, but it's still voluntary. And if you were to certify to the certification program at whatever and certify to a particular version of USCDI, it means that you would have to be able to demonstrate that you can exchange data using these standards. That's the extent of the requirement. Now, out in the wild, how an EHR is implemented and whether or not it supports those things is sometimes an open question. But USCDI is one of the certification criteria that I mentioned are part of what we call a real world testing program. And so what this means is if a user of an EHR notices that something is not working the way it's supposed to, not being able to represent labs with low ink codes, et cetera, that can be reported to ONC, and there will be it'll be noted, and then ONC will work with or the certification bodies will work with the EHRs to ensure that that compliance is there. So that's the real world testing is how we make sure that it still does it.
That one. So when you say the real world testing, do you have certain hospitals that are your real world post implementation? It all has to come from voluntary back to you as to what's going on, or how do I guess, because we are doing some of these things at there's 22 hospitals in the REDS 4P, and I'm on the QC, so I see the crossover of the data, and the fidelity is all over the place. So I wondered, and I wanted to say that out loud because I don't know that it's being transferred as nicely as what is being here. So it might be a little difficult to say we could do this, know what our antigen antibody, for instance, as an example. So
it's the real world testing program is a particular a certified EHR product or a certified health IT product is one that has gone through testing and has attested to the ability to do the variety of criteria that they are certified to do. So if they were to update their systems to USCDI version 2, which is currently the next version that's available, or USCDI version 3, which should be available this month to be able to update. So if an EHR, they don't have to go through the whole certification program again, but an EHR does the work to update their systems to the new version of FHIR, the new version of CCDA, the new version of USCDI, then they attest to the fact that they can do that. And there's test methods, there's things that we can do to prove that, but it's the responsibility of the vendors, the developers, to do the development, do the testing to make sure that it can, and then attest to it. And it's the real world testing means that if it's identified, so the vendors are on the hook for doing the work to provide an updated product to their customers. And the real world testing, they're subject to monitoring. ONC does not go out and touch a variety of different hospitals to say, like, is it really working? But if it's reported that it's not, then it sort of comes to, it rises to the attention of ONC and the certification bodies.
Scott?
Thank you for the presentation. Learned a lot. Can you go back to a slide, though, number 39? So you mentioned there's flexibility in the system. So if there's a different kind of product code other than ISBT 128 that's used, that's to identify a product, or if it's a UNOS number for an organ, does that fit there as well?
So number one, this has not been adopted in the version of USCDI, but should it be, it doesn't preclude an EHR from representing tissue products with some standard based on if it can be implemented on more as a one-off in a particular EHR or in a particular hospital where it is able to capture ISBT 128 or as the product codes for those. What it means to have an applicable standard, should it be implemented or should it be part of USCDI? It means that at a minimum, an EHR must be able to represent a product code with ISBT 128. It does not mean that they cannot also represent it using UNOS. But that's what it means to be an applicable standard in an updated version of USCDI, for example.
Okay, so it does have flexibility. Beyond.
Yes, it just, at a minimum, must be able to demonstrate the ability to capture and exchange using those standards.
Okay, thank you.
Sure.
I have a question. It's a multi-layered question. What is keeping ISBT 128 from becoming part of an accepted code that can be transmitted? And can various branches of the U.S. government accept that data? Currently, hemovigilance in this country is largely manual. But if ISBT 128 codes are applied to hemovigilance and accepted into your framework, then presumably the NHSN would be able to accept those codes and do hemovigilance in an automated way. I might have just thrown around too many acronyms, but
no, I'm tracking so far. But how many layers more do we have?
Is this feasible?
So NHSN sets the requirements, and if they set the requirement that product codes have to be ISBT 128, then that's what the requirement's going to be, and it's up to whoever's sending the data to NHSN to either store and transform, store and transmit, or store, transform, and transmit in ISBT 128. It would be up to them, right? As of that's because it's not part of certified health IT. That's how that could work. But we don't have any sway over NHSN about what they must require. We don't have that for anything. We don't require that Medicare. We don't have a sway over that Medicare requires certified EHRs, or what's we don't dictate what the programs require. But there's another way that could be if they would accept this standard, a standardized way of exchanging the data using these standards can be developed. And if the reporting is done through CDA or V2 messaging or FHIR messages, a use case specific implementation guide can be developed based on USCDI, based on US Core, based on some other standard that has a standardized way of exchanging the data, possibly with NHSN, possibly with the registry, possibly with some other recipient, and then it would be up to each site, each hospital, each EHR as to whether or not they want to implement that guide, so that they can say we use we use a FHIR implementation guide to exchange human tissue data, or blood type, blood antigen, blood antibody data. And that would be a different way. That's not part of regulation. It would at this point would be a voluntary program, but that would be a way to do it. Would also leverage the capabilities of certified EHRs to be able to help You don't have to build an entire new IT system if you leverage the capabilities that are already in place in EHRs.
Thank you. Jed and then Sridhar online. And then I think we need to close the, wait, I'm sorry, Sridhar, Jed first and then,
Okay,
then you.
Sure.
And then I think we need to close the questioning and move on. Thank you.
Actually, Sridhar, I'm going to do a softball to you, which is a recent large-scale tissue lookback was greatly hampered by lack of standardization of tissue tracking. So my question was actually for Lou and Dr. Brubaker, are tissues labeled in a standard enough way that we're ready to implement a mandatory product tracking by EHRs?
Okay, I can take a stab at it. The reason I asked my question is along the same line, in that this last entry line here for the unique identifier, we'll have to go back. As long as the character field isn't restricted, and there can be an entry made to accommodate any unique identification system used or code, because it can be others than this one, that work very well too until they get to the hospital. But if they can be entered, there's a possibility that it gets entered, and it's really nice if it can be read by a handheld machine and barcode read, and that uploads that number or all those characters. That would really work.
Right.
Universally, that would work.
Right.
Instead of trying to restrict it to just one system, like there is one system for organs, and there's basically one system for blood.
Right.
Blood units.
And we have something similar to that for implantable devices. So we have one of our data elements that's buried in one of the early slides is the unique identifier for implant. Yeah,
UDI. Yeah, I saw that.
And that's so whether that's implemented as a barcode readable or stored like that, that is the standard for FDA regulated implantable devices. And so that stands as an example of how it could be done by implementing. If this is implemented, it could be implemented like this and reference a standard like FDA UDI.
I was looking at those first three versions you put up there, and I was scanning it for something like this. I was wondering, where do the tissue products go in that larger scheme, and where would an organ transplant number go for a recipient?
Yeah, the way that can we go back to second or third slide? I think the slide with that one.
Yeah.
So the way that these are organized, and I describe this, and I might get in trouble with my bosses, but I describe this as the data classes, or what I just describe as visual organizers, right? So they're arranged by common theme, common concept, and so you could put, if you had a UDI, it could go into it could be a lab, it could be a device, it could be maybe a clinical test, it could be, it's not a great fit. Or we could have we could have a separate data class for, tissues of human origin. I mean, that's as a broad category. But don't focus so much on the data class. We would add it to. We could potentially just add it as lab. Or maybe have a different one for. We have we're changing the name of the UDI data class to medical devices, or we plan to, and so that's that's not a great fit either for that. But again, we would come up with a logical place for it, or create a new data class. But it's the data itself, not the data class that it's in, that's the important thing.
Yeah, thank you.
Just quick.
Sridhar and then.
Yeah. Can I ask a question? As opposed, what's the barrier for requiring or adopting this tissue into US CDI? Because I know you said that it hasn't been adopted, it's still proposed. So why isn't it required yet, or why isn't it adopted?
We have had literally hundreds of recommendations for new data elements in US CDI, and we have over the 3 years that we've been updating USCDI, going into our 4th year, we have had to be very selective about the data that goes that's added, because each new data element has a burden on developers and a burden on implementers and standards developers as well, who might develop an IG or update the US core IG to accommodate new data elements. And so we have a prioritization criteria, which is next slide or the one before that, that have, and these are the areas that we focus on to add new data elements, because we literally have several hundred data elements that are being recommended that have not been added to USCDI. And so I know that's not a satisfactory answer for folks working on a particular use case. That's what we have had. That's what we have done over the last several years, and that's why it has not gone into USCDI, and that's why a lot of things have not gone into USCDI.
So is this like a permanent arrangement? At some point, will it be adopted, or is it just forever going to be proposed?
We go through this every year. We go through a cycle of considering and adopting data elements, new data elements in every year. And our prioritization criteria, might change, develop over time in response to a variety of different forces. We will consider it each time, and we will respond to public comment. We'll respond to new submissions for new data elements, and then make a determination based on the last of these prioritization criteria that are on screen is the aggregate lift, and so whether or not all of those put together. I mean, any particular recommendation for new data elements is a potentially fantastic idea that will impact a lot of people, but it's the aggregate lift that has to be taken into consideration when we add and consider how many to add each time around.
I am sorry. The conversation's been great, and this is obviously a topic of great interest. I think the next speaker will be adding to this topic, so it's a good flow. And I think we're going to need more time the next time we meet on this topic if we could
Sure.
invite you back. So thank you so much. I'd like to introduce Dr. Tim Pruitt, who will give us an update from the Tissue Biovigilance Subcommittee. Thanks, Tim.
Thanks, Claudia. First of all, I want to thank the ACT-BSA for the opportunity to talk, and particularly the staff who's facilitated and helped us so much during this. You've been very helpful. Claudia, thank you for putting this together after listening to me rant at home. And I want to thank my co-chair and lead, Scott, for he speaks government talk, I speak doc talk. And so let me just give you a very brief issue as to why this is, and it really is important that we get along, and we're going to put together something that I think hopefully both of our communities can actually understand and make the system better. I'm a transplant surgeon. I've put in organs to people, and they've gotten stuff they didn't want. I had one colleague who put in a liver, and she got coccidioidomycosis and died. That's not the end point. The goal is to give us safe products that go from one person to another. And this is where we're coming to deal with it. I've had a long-term interest in biovigilance. I'm an ID doctor as well as a surgeon. I've been on the DTAC, which is the organ side of organ transmissibility or disease transmissibility through this, and part of the HOPE Act stuff. I've been very interested in this on a global sense, and we've been part of the World Health Organization Notify project on all of medical products of human origin and how to make them safe. So when at the last Notify meeting, we had discussion about the TB transmission through tissue products, I came back and talked to Claudia, and this is how we got to where we are today. Our process with tissue biovigilance is so much different than organs. Organs, I send my fellow out. He goes to a place that's already been matched donor recipient, and he goes and gets it. He brings it back and he says, this is where it is, and we go in. Tissue biovigilance is so different. I mean, there's a donor. They may or may not have given organs. They give a variety of different products, eyes, bones, skin, all the cardiovascular stuff, you name it. Some cells, some are. And then there's a handoff, and it goes to a processor. And then there's another handoff after it's been processed, and it goes to a distributor. And then it goes to the hospital facility, and then it goes to a patient. It is nowhere close to what we do. The blood transfusion stuff is also different in the sense that it goes from the person's vein into a bag, it's manipulated, but then that product is identified and tracked to a specific person. There's pretty much just a very limited amount of people who actually touch it. Tissue, a zillion people touch this thing. And so when we had the TB transmission that was been discussed, it turned out, it brought to bear that there are a number of different people who touch the tissues that come in our country that go from one person to another. And then, so the question is, what is our biovigilance processes that we have in place, and are there gaps in how they get done? So what we have done, let's see, let's just, do I have control of this thing? Yeah, sort of. Yeah, there it is. Okay, so this is us. And this is just to describe what we've done. So what we've done now is we've put together a biovigilance group, which is comprised of 4 different work groups. We have a work group of people who actually procure the tissue, touch the tissue, identify the donors, try to get a risk assessment. Is it clear? Is this a tissue which should be done? We then look at the handoff. And then we have a second group, which is the tissue processing group of people who take the product from the people who procured it to put it into the processing, to put it out into another endpoint, which is the end user, the consignee, the people who get it from the tissue processing elements into the hospital systems. And then finally, the people who put it in and the ones who get it, and how do we recognize that everything went well? And how did we not recognize how everything went well? And the goal is for nothing to happen during this except for the recipient to get what they want. I have an implant in my mouth. I have somebody's bone in there so that the screw, the set thing was in place. And I don't want anything to happen other than the fact that I have an implant in my mouth. And that's the way it should be. But unfortunately, things don't always go the way they should be. And so where are the gaps in this process of tissue biovigilance? And what are we willing to accept and what are we not willing to accept? The goal for each of these groups is to identify and document the gaps of the processes in their area of expertise, both in the legalese or the regulatory language and in the practical language. I can talk about how we get around regulation all the time in the healthcare system, which isn't necessarily good for the person because our regulations don't necessarily fit the way we practice medicine. So we want to consider the existing controls, manner the compliance is assessed, and the steps that are inclusive of deceased donors as well as living donors of tissues. And so we're not just stuck on the dead donor components of what we get, but we're looking fairly broadly. There are certain things that are outside the scope of the authorization, which are listed there. So far, we've had 2 preliminary meetings with our first 2 work groups, both the tissue source for donor identification, consent authorization, screening, decision to proceed, tracking, coding, records, et cetera, and also with the tissue processing groups as to where the fits go. We have 2 more groups to meet. Both of the first 2 groups want a second meeting, at least, to rediscuss issues as they've kind of mulled over the thought patterns. We haven't even started on that. In terms of the tracking and coding components, that is something that we're very interested in. We've asked for compliance, if you will, from Epic and or Cerner. And they're a little bit hesitant to try to get through because of proprietarial related issues. I think we're going to be able to get someone involved. The question is the electronic medical record is good for biovigilance or hemovigilance or organ vigilance efforts as it is for billing, coding, and inventory, which is the primary end, at least in my assessment of why the EMRs exist, is for business-related issues and not patient care-related issues. And we need to ask what kind of biovigilance efforts, what kind of hemovigilance efforts are built into our electronic medical records, which actually benefit the people who we enter all these bits of information into. So, like I said, we started our work groups. We're going to continue to have them. We will report back to you as we go on. We've had two summaries of the first pieces which have come through, very gratefully edited by Scott, and that's it. So with that, I tried to get back on time. I didn't know if I quite made it, but I'll be happy to entertain anything. Scott, do you want to edit anything I said?
One comment. If you go back to a slide we skipped, it does mention the two articles that were published that showed the effect it can have. It's one right before this. Yeah, there you go.
Yeah. Okay. Yes.
When you look at what can happen, and in this case with Mycobacterium tuberculosis, it can affect the healthcare workers that provide care to infected recipients too. And Sridhar could speak to that better. I think he had a hand in that second reference there that was published that looked at that as well. And that even makes it more serious if you want to even approach it that way. But this was really the biggest, more serious event, I should say, in tissue banking and tissue transplantation world in the United States ever, because of the morbidity and mortality that happened, that resulted from it.
I mean, the issues of this are really very phenomenal. I mean, we are focusing predominantly on this one on hospital-based use of tissue. I mean, my bone in my mouth is outpatient. There's a whole series of my tissue that is in my mouth, according to the little card that I came from Sweden. I don't know how much tissue is imported in the U.S. And how it gets used, but I have Swedish bone in my mouth, or Swedish processed bone. I don't know where the origin was. It may have been from, Serbia, for all I know. But the question is, does it matter? And the answer is probably. But it's a very interesting issue as to how we trace and track what we use on our patients every day and the safety related elements moving forward.
Question from Jed and then Cassandra.
So my center is the proud testing center for the Iowa and Minnesota Mother's Milk Bank, and they do incredible job, nonprofit, incredibly compliant, but it's a little bit of a wily world out there. And I think it's our own Cassandra Josephson that documented in a NICU 24 cases of CMV transmission, 23 were from mother's milk. I think hopefully the patient's mother. Maybe you can comment more, but where does milk banks fall under this tracking? And
well, just when it's donor milk, they pasteurize it. So they do testing of all the mom, all the things that we sort of test for in the blood bank world, and then they pasteurize it. But that's not the case for maternal milk. So that's the answer there. But as far as who is regulating all of that, I don't know. But I do want to comment though on this isn't new. This 2021. I mean, I went to the CDC and spoke about the UDI and traceability, trackability around the time that the rabies, with the vessels that were from a liver transplant, and those vessels went to somebody else, and the vessels, which were now considered a tissue, or sort of they were living in organ tissue.
It's an organ.
Now it's an organ.
It's
okay.
an organ.
There was a time where it was kind of like not classified, not otherwise specified.
Yeah, no.
But when that was, but the point is the same, right? About the splitting of these different things to different recipients. Right. And we were talking about this traceability, trackability issue, and it would seem to me that we now have much better, and we were using Epic at the time, talking about how to solve this when Matt Kunert was at this, CDC. But it's the same issues of where those numbers fit and whether those numbers are able to be captured within the medical record. And we have problems with blood. We do audits all the time in the modern medical record, and things are not being documented correctly because they're not standardly put into a path that you can barcode it. And all of these are implantable things everywhere. And so I feel a pressure that it isn't just tissue, even though we had a centralized tissue bank, and so I'm used to that part, but blood, organs, all of it. And why are UDC, why did they get the special place that they get to have an implantable barcoded thing, and the rest of us have biologics, which are not drugs? And so that seems to be where our big gap is. I just wanted to.
I think, we are going to keep diversifying what we implant from one person to another. I mean, with the gene manipulated cells, we are just going crazy over what's going to happen. And the notion of gene manipulation of cells doesn't necessarily get rid of all the other biologic issues that are related to the transmissibility of cases. I think we need, we're focusing only on tissue here, but what you bring up is a much bigger issue about trying to make sense out of moving products that go from one human being to another. And whether they're blood products, whether they're tissue products, whether they're organs, whether they're manipulated, whether they're not manipulated, we need to have some sort of commonality of language, because we use them, the Canadians use them, the Europeans use them, the Australians use them, East Asia uses, everybody uses this stuff. There's a lot of issues with tissue, which is here. We ship tissue around the world. We supply up to 30% of the global. Do we have of global tissue? Do we have an accountability and responsibility of the rest of the citizens of the world? What is our, I can go on and on about this stuff, but I don't have all that time. But there's a lot of issues here as to say, how can we establish good practice, commonality of language, and most importantly, responsibility of the people who get these things. I mean, I think that is our notion, at least my notion as a doc, is I'm responsible to people who come to me to give them a product what they want, not what they don't want. And that's what we're trying to come up with, is some sort of place between regulatory and practice to figure out how can we do it better.
Dave Stronchek, then Sridhar.
The field of cancer, cellular cancer immunotherapy, which are generally gene manipulated, that's exploding.
Yeah.
And there's autologous and allogeneic products, and I'm not sure how well it's tracked.
It's not as well as we think we would want it to be, but it's part of this issue, not this particular subset issue, but for the program and for the we need to go. And I'm not going to go.
Sridhar.
Yeah. Hey, Sridhar.
Yeah. Hey, have you thought about, as part of this at all, Tim, have you thought about the requirement for informed consent for patients? Because I'm guessing that most people out there who get a tissue product are never subjected to informed consent that they're receiving a human product in the same way that blood transfusion and organ recipients are.
Yeah, I mean, that's part of that's our work group 3.
Yeah.
Or 3 or 4. I can't. It's 3 or 4. I mean, in that we have a couple of. We have both the orthopedic group and some surgeons as to what they do and don't do. I mean, I can tell you when I got my bone implant on my tooth, there was no informed consent. He just said, I'm going to give you some bone because it needs to go there for the screw to fit. And there was no risk benefit analysis. I don't think the non-transplanting, for those of us who do transplant for a living, we have to go through all this stuff because it's so part and parcel of what we do. If I'm a general orthopedic surgeon, I may or may not use stuff. I typically would view human tissue as a device, as something which is akin to the screws and plates I put in. It's just something that helps the process go better to get to where I want to go. Same sort of thing with lots of things like skin from the burn units. I've had a couple of discussions with some of the burn surgeons. It's a tool that is used, and it's not necessarily thought of as a risk component. It's a benefit component, and that's an educational issue. I don't think you can regulate that, but the notion of how to get into appropriate use and information to the recipients of what this is and what it isn't is, I think it's an important issue. Whether it's the same threshold we need to use for informing our organ recipients is a different issue. But I'd be interested in your thoughts as to where it goes, because it's going to be where's the risk and benefit, and is the benefit outweigh the risk? And
I think that if somebody is getting something with live cells, they have to be subjected to informed consent in the same way that we would have an expectation that somebody getting a blood transfusion or an organ transplant are being appropriately subjected.
I would be
to informed
inclined
consent.
to agree.
Yeah,
they seem to be of the same genre.
Yeah, that's it. We had an asterisk by, what we were going to cover in these groups, and they can change. These lists can change. And what you just described, Sridhar, can be added to work group 3, maybe 4 as well, but 3 for sure. So we'll do that. We'll make sure that's discussed at the first meeting. But I know this advisory committee had discussed this at a couple of meetings before I joined the committee. There were meetings entirely about informed consent, I believe, for recipients and how that works and what needs to be fixed. And I don't remember, there probably were recommendations made, Jim. Yeah. So that was already addressed, I guess, in the past, but possibly nothing changed.
I was under the impression after the BTS scandal and the Joint Commission stepped in that, like, a long time ago, that changed a lot of things in pediatrics. I mean, there were a lot of children who had to be retested, and definitely even in our place. And so we implemented big time informed consent, almost to the strictness of blood transfusion, which there was a lot of pushback in the beginning. But there are these risks, and people need to know about them, especially with homographs and, things of that nature. So I just want to add in that we should think about pediatrics in a little bit of a different way as we start to talk about tissue. And maybe you could add that to one of those subgroups, because assent, consent, all those pieces are even more complicated, but are really, really important for how long these patients are going to live for, hopefully.
And the kids issues for tissue is much different than adult issues. You're spot on with that.
One more question from Lou, and then we're going to close this and move on to the next speaker.
I'll make this brief. Accredited member tissue banks have this at the forefront of their education effort to their customers. That informed consent takes place. Most that I'm aware of provide materials. Now, how effectively those materials are used by the clinicians in educating their patients about what the treatment plans are is where I see the gap, that last mile in that process, is how effective it is. And how effective depends on what risk the treating clinician is associating to the tissue type. Many of the tissue types that come from accredited member tissue banks are terminally sterilized, highly processed, devoid of cell or cellular components. But some of the newer class of products are very rich in active cellular components. So I'm not sure, and this is what will be interesting, what emerges from the gap analysis, is how the clinician is treating that. Do they treat cellular products or something on that verge different than they do a morselized ground bone that's terminally sterilized that they may treat capilarly?
There's been a lot of literature about the differences between terminally sterilized and decellularized products as being they're much more akin to device kind of things. The cell products are the ones that carry a fair bit of risk associated with it.
Okay, a lot of good discussion. Thank you very much, Tim. We're moving on to Ann Aiken, who will give us an update on the Giving Equals Living campaign. Final update. I hope it's not final because we're making a recommendation that it be extended.
Good morning. It's a real pleasure to be here today to talk to you. It's been a passion project for our office to do Giving Equals Living, which is a blood and plasma donation campaign that we launched last August. I think many of you do know about this campaign. You may have even seen some of the materials I'm going to show you today, but just in terms of level setting everyone, when Congress passed the CARES Act, they asked us to take on a national communications campaign to address the severe and unprecedented shortages caused by COVID-19. And I don't have to tell this group that donating blood is life-saving. And so we were really excited to get started. And I'm going to talk a little bit about what we did, but we basically did launch the campaign in August, and our contract ended to support the campaign in March of 2023. But HHS is still supporting certain components of it. So we don't have a paid staff. There's a whole bunch of people. I'm here today to talk to you, but there's a whole bunch of people that really participated and supported this campaign, including Sarah, Allison, and Lauren, and Jim Berger from my team in the Office of the Assistant Secretary for Health, Tim Harrison and Kay Hayes, who are our leadership. There's a whole bunch of communicators at HHS who don't work in our office, who help support the website and other things. And we had a whole team of really wonderful contractors to work with on this. So as a good communicator, and this is sort of the health communications process in a nutshell, we did what we call formative research. We were also told through the CARES Act that we would do expert panels. And so we did a literature review, an environmental scan, which includes looking at existing campaigns and informational materials that are online, looking at what people are talking about on social media, and then what's happening in the news around blood donation. We did 28 focus groups, which I can tell you is a lot. And then we did 4 expert panels, which included people inside of government and outside of government. And just to really boil it up, what we found is that the public is generally uneducated about both the donation process and the eligibility requirements. A lot of people, they know about giving blood, but they're confused about certain parts of it. And then there are barriers to getting people to donate, such as a negative donation experience, in particular, a negative first donation experience, and perceived inconvenience of having to go somewhere, a lack of access, and also mistrust of the healthcare system. And then motivators include altruism, incentives, which can include, money or a gift card or a T-shirt, or a personal connection to somebody who's in need. And then also understanding the donation process really helps as well. So from all of that research that we did, we developed sort of a charge or an objective for the campaign. And our goals were to increase the number and diversity of Americans who understand why blood donation is important, what blood donations are used for, and what the process is and what the eligibility requirements are. We also wanted to increase the number and diversity of people who believe donating blood is important and the right thing to do, and that actually do donate blood and make it a habit. So we had lofty goals, as you do when you start off. And then we did do quite a bit of brand testing. And so this isn't all the stuff that we tested, but those are 4 examples. I think we did like 8 or 9 around these 3 themes. So altruism, or underscoring how donations help others; social norms, which is driving the perception that donating is the right thing to do; or peer-to-peer engagement, and just reinforcing that there's a value in doing it together. I really liked that one when we were going into it, because I thought, we can get more people in the door if you bring your mom or your friend or your family members. And this is why you test, because the ones that I like the best didn't test that well, actually. And the spoiler alert is that top one there with the mom and the daughter is what overwhelmingly tested well across multiple groups. So from that, we evolved it into this brand here, which is our brand. It has a sort of Dear Hero approach, which tested super, super well, and features testimonials, which are real stories from people who've actually received blood transfusions. And then we took that and those stories, which are on the website, we made video ads of them. We made bus board ads of them. We made social media ads for them, et cetera, et cetera. So it all sprung from that. And I'm just going to talk about these three individuals. We have more that we've featured. But Heather is a mom and a photographer from Dallas, Texas. She has sickle cell disease and has had hundreds of blood transfusions to help treat it. Earl is an Army veteran and a motivational speaker from Scranton, Pennsylvania. He was badly wounded in a roadside bomb in Afghanistan, and he lost a lot of blood and needed to have his leg amputated. And then Cesar is Spanish speaking, and he's a musician and author from Atlanta, Georgia. He was in a car accident where he was struck head on by a drunk driver, and he had numerous broken bones and a shattered face. And so blood transfusions helped save his life. And so from this, we did test these stories, and they really tested very, very well. The message that blood donation saves lives was clear and compelling to people. They liked that emotional pull. And on one of my slides, I had a quote about how a woman in a focus group talked about the emotional pull of that. But they also really liked statistics. And that really helped to inform, that emotional reaction that you have has meaning. And the other thing that we learned is that we really should talk about specific conditions and keep them to things that people sort of readily know about, like childbirth. The video testimonials were really, really important to this because they really provide the context and the details about why recipients need blood, and understanding how blood donations help the recipient and their families also really helped people remember the message and really connect with it. And then, the reason why it's called Giving Equals Living is we're showing people living their lives. So that came out through in the testing as well. And so I'm going to attempt to play this video of Heather. This is our long form video. It's each of these people we featured has about roughly 1 minute video. And this is the one for Heather.
I have sickle cell. It's a genetic disease, so I was born with it. And I have struggled with it throughout my entire life. I've had lots and lots of blood transfusions over my lifetime, probably in the hundreds. I have a son, and after I gave birth to him, my hemoglobin dropped very, very low. It took upwards of 2 days to get that blood that I needed. I don't often fear for my own life. I fear for my child's life. The idea of him not having me around. When I was in college, my brother encouraged me to do what I loved for a living, and that was photography. I'm enjoying seeing things through a new lens. I'm most grateful that people are willing to go out there and take their time, their blood, and give me new life. Dear Hero,
Okay, I was going to show another ad, a 30-second ad, but I'm having trouble doing that. So here are the lists of the different videos that we had, and I'll just sort of summarize this for you. So we had 16 different videos. They were the long form 1 minute videos. We also had 30-second videos. That's on purpose because that's what TV stations like to play, 30 seconds. They also really like 15-second ads. because that's the kind of world that we live in. And so you'll see that each one of them, got different kinds of views. But the 15-second ones really performed very, very well. And so like the Earl's got 1.9 million views for his 15-second ad. And while Cesar had less views on our YouTube site, he had the highest performing 15-second ad. So one of the things I really wanted to mention is that doing multicultural really well is beneficial and can help drive your objectives. And then here's the website. So this it's a pine green. I don't know how well that's translating that first image there, but that's where we have about the campaign. It's where we have all the materials that people can use. And then the red, of course, we like red, is the website. And that's for consumers who maybe are thinking about donating, have donated, want to talk to somebody else about donating. We also have the website in Spanish. And then a big part of the website is to feature calls to action. So they're peppered all the way through. And we're driving people to donation centers for the most part as the call to action. And so we partnered with the Association for the Advancement of Blood and Biotherapies, or AABB, which I'm sure you all know. And we used their donator. And that was just really, really great. So we are, they're coming to our website to the ads and the social media and all of that stuff, but then they're going off to hopefully get to services. And then this was a really fun project. So how many people here are active on Facebook? How many people here have used what's called a Facebook frame? Just one of these little guys right here. Okay. So basically, this is somewhat popular on Facebook. So you have your image that you put out to the world, and you can put these little frames around it. And so this is what we did. And you'll see the data there. There were a little over almost 9,000 Facebook frames that were used in English, a little over 5,000 for Spanish. But then one of those frames, which I think we had like 8, was able to garner 807 views from people. So there is an expansive quality to it. And then we also had gifts that people could use. So these blood donors save lives, or I gave blood. And I was using these. It was a really good way to connect with people, some of which I hadn't talked to in like years. Literally people I hadn't seen since college who, had a connection to giving blood. So it was an interesting way to connect with people I hadn't connected with. And then we did normal media interviews. Emma Levine is the spokesperson for our campaign. So she spent quite a bit of time talking to the media when the campaign launched and then throughout the course of the campaign. And then we also did a fun challenge, which is where we encourage people to be innovative. And Jim Berger was one of the judges that we had. And we asked them to develop community-driven strategies to increase or diversify blood and plasma donations. It closed on December 5th, but we did award 9 awards between $1,800 and $10,000 to these groups here. And just in terms of key metrics, we did a lot of metrics, but through the organic social media that we did at HHS, we reached more than 66.7 million people. And those YouTube videos just on the YouTube site generated more than 4.5 million views. In terms of paid media, we were able to get about 54 million impressions. And then we did do paid media through social media, or through websites, and that generated about 676,000 clicks. And we also were able to do pretty well with donated media. So this is where we didn't have to pay for the airtime. And that was a value of a little over $4 million. And then the CARES Act asked us to really look at geographic information. I'm not going to go into a lot of this. We did collect it. And I think what it really shows is that we were in a lot of like small to medium sized markets. We did, I don't have the data here, but we did have some larger markets and some like social media things that we were doing. But in terms of donated media, we really saw a lot in English from Montana, Virginia, and Mississippi. And then in Spanish, it was mostly Connecticut and Massachusetts. So a wide range there. But I think one of the lessons from the health communications theory that we have is just that you want to reach people where they are. And so you want to employ these different tactics so that you have a better chance of doing that. And then we also looked at race breakdowns and some interesting things here. This is just for some select ads that we did. We do set benchmarks when we do this. So we had a benchmark that was common to these kinds of ads. And we pretty much overwhelmingly exceeded the benchmarks that we had. And these ads that we looked at, both by general market, Hispanic, and Black audiences, we exceeded it by about 8%. So pretty straightforward there. When we looked at the pre-roll ads that we did, which is what would play before a video, we were basically there at 9% for general market and Hispanic. But then for Black audiences, it was down a little bit by 2%, but still exceeding what our benchmark was. And then for connected TV, we were at 7% for general market, 2% again for Black audiences. And then the really surprising finding was that we exceeded the benchmark by 38% for Hispanics with a video completion rate of 94%, which is outstanding. And then in terms of next steps for the campaign, we are still promoting it. We're looking for sort of some of the normal things we would promote for, like donor month in January. But then Kay Hayes, the director of our office, was also pegged to be an advocate around National Women's Health Week. And so we promoted several things, but this campaign was one of those things. And like I said, when I started, we have all the promotional materials. We also developed a suite of educational materials, which I haven't really talked about that much, which cover those things that we found in formative research that were important. So if people want to go to, a recruitment effort and print out something, or they want to send it to somebody via email, they certainly can do that. And then just a couple of thoughts moving forward. The testimonials and materials perform very well. We know that the participants that we tested them with felt connected to the stories, and that seeing people like me really helped us with our goal around more diversity. And being relevant really helps. So audiences need to know how donations helped recipients and their families live better lives. And I think that's one of the strengths of the campaign. And that really helps with empathy, understanding, remembering the message, that kind of thing. And then I alluded to this earlier, it's really important to pair the stories with statistics and use familiar conditions that people can relate to. And then one of my goals in speaking to groups about this is to let people know that these materials exist and that they can be used. They're paid for with taxpayer dollars. So we really do encourage people. They were tested and they work well. We do think that more time in market, to your recommendation, would create additional needed opportunities, in particular with making donations a habit. I think we just need more time. And then clear and memorable messages, are still needed. I think they are needed from a variety of sources. We really do need people to drive home the message that blood donations save lives, and that developing habits around this is really important. And we also heard from some of our recipients that they wanted more information on personal risk. So I'm saying that I think that this is a good idea to address some of those things. And that's it for me. So I don't know if anyone has any questions or if I went over. Thank you.
Yeah, Cassandra first. Thank you.
That was awesome. What a tour de force going through all that. I had two observations. One was about children and one was about cancer.
Yeah.
And I don't know, you alluded to this a little bit about you were surprised about what you maybe thought would be and what
Yeah, I mean, that
audiences-
happens. You're not always I mean, I am the target in this because I am a blood donor, but often when you do these things, what we think of as people who are invested in health and like certain things don't necessarily test well. And when you see audiences reacting, you learn so much. You really do.
So was cancer not something people reacted to or small children?
No, they did. And we do have some cancer recipients, including a child that we featured. One interesting story from the focus groups I'll say is there was a woman whose mother unfortunately passed away from cancer. And she had recognized that blood transfusions really helped her at the end of her life. But she was skeptical to donate. So it was, but you did see that light bulb kind of go off like, oh, this could help other people. So sometimes I also think we just need to really make sure that we're driving those messages to people because they want to help and they think donating blood is valuable, but sometimes it doesn't get into, an actual behavior.
Ray?
Very, very important work that you're doing. I think it's terrific. One question that I have is, it's clear that you're getting to the audience that you're trying to target and you're getting their attention.
Mm-hmm.
Is it affecting their behavior? What are your metrics, or are there approaches that you could use to say that you've converted non-donors into donors? And what does that look like? How is the message being effective that way? And I guess as part of that, we heard some disturbing figures yesterday about the number of donors under the age of, I think, 30 or 40. The numbers are decreasing dramatically. And so is there a way to look at the impact relative to effectiveness in a certain population? It seems like a lot of your work is targeted towards that group of people in terms of the social media and other network approaches, which is fantastic. But I'm wondering, is there a way to measure the outcome relative to changes in behavior?
So not like what you want, not without a lot of money. And I would love to do that research. I think it would be great research. I think we would learn a lot from that. But you need to basically do sort of pre-evaluation, and then you need to do post-evaluation. And, we are driving people to a locator. We know that we've increased, and we can kind of tell from the metrics that you get on websites who your referrals are. So we've been watching that. So we kind of know that. But that doesn't necessarily mean the person ends up, donating. So a lot can happen in between getting the first information and actually donation. So we would need to do a little bit more research. We did do some interesting research at the end of the campaign with Connected TV where we looked at some of that, but it's not a large enough sample to really draw any major conclusions or break it out by age or anything like that.
Jim McPherson online.
Hi, hold on. My question is sort of similar to what was just asked, and that is when the blood organizations worked with the Ad Council some years ago, they did a lot of research in terms of pre and post attitude and that sort of thing. And you said that takes a lot of money. I'm just sort of curious as to what is the next steps on this, and have you thought about approaching the Ad Council, or since they do this that's what they do?
We have not talked to the Ad Council. They usually do want money, by the way, and for previous work I've done with them. So we would just need more funding, and we're trying to get the funding. We don't have any yet, though. So we are continuing, like I said, to promote on social media and to work with different groups. And part of our goals were to make sure we had something available for when you need surge. So that exists, and that sometimes is a way to get additional money. And that's certainly how this campaign was also paid for, was with COVID funds.
So this might not be a real question, but if we do recommend that this work continue, you feel that there is plenty of work to be done?
I do. And not just, like I said, I think there's a lot of work to be done on the promotional side. I think that there are some more materials that can be developed. And I think, in particular on the on the evaluation side. We've done some things, but we haven't done a survey.
Any other questions from the room or online? If not, thank you very much.
Thank you. Take care.
Our next speaker is online. It's Brian Blicken, who will talk to us about methods to extend the outdate of blood bags.
Yes, hello and good morning. First of all, since I don't normally use Zoom, are you able to hear me and see me okay? I guess that would be the most important first step.
We can hear you and see you. Thanks, Brian.
Okay. All right. Perfect. And then will someone be forwarding the slides, or is there a way for me to do that?
Yes, just ask them to forward and it'll go.
Yeah. Why? I'm sorry?
Yes.
Okay. Then if we could move to the next slide. Okay. Again, warm welcome and thank you for having me here. I was, again, my name is Brian Blicken. For those of you that don't know me, I'm currently Senior Vice President of R&D with Fresenius Kabi. I've been in this industry about 30 years and have history also going back to Fenwell and Baxter days, been involved in this industry, like I said, almost 30 years, and that's involved the design and development of a number of blood collection devices. I was asked today or invited today to talk a little bit about what, some of the considerations involved in extending the expiration date of blood collection products. As I understand, while I've not been involved so far with this committee, I understand there's been some discussion about, ways to improve supply, and especially in future potential crisis situations, and ensure broader availability of products. And certainly that's interesting and a good effort and something that should be considered. And one of the discussion points I understand was on potentially extending the shelf life of collection products so that they have broader coverage and availability. What I hope to bring across today is at least a set of considerations and maybe some discussion points that both the committee and the regulators could take as a part of that discussion. I will say up front, this is not a trivial topic and does have several facets to consider. And I think that it would probably be welcome to have further discussion in the industry between the manufacturers, regulators, and other interested parties on how this, again, if it is a goal, could be best and most perhaps economically, but also safely achieved. So with that, I have a few slides to maybe give an overview of some of the considerations that manufacturers do deal with in the design and development of products. And then, like I said, maybe some questions that would be relevant to discuss as we would aim to, find a path forward should this remain a goal. Next slide, please. So again, just a quick overview for those that might not be as familiar with what goes into the design and development of products that are used for blood collection and processing. And what I've attempted to do here is outline nothing that is manufacturer or product specific necessarily, but more general considerations that I think anyone in this industry providing such products would typically need to address. Again, when we are designing and developing such products, of course, part of that is to identify the shelf life over which we believe such a product could be used. And ultimately, a lot of data goes into supporting said shelf life, which includes the laundry list of things that I've outlined here on the slide. For sure, product integrity is one of the first and foremost requirements, both for the packaging, but also for the set itself. And again, whether I talk here something as simple as a blood bag or as complex as an apheresis kit, then these requirements still largely apply. And over the course of a product shelf life, we would be needing to prove container closure integrity, set integrity, things like caps, ports, tubes, everything is remaining intact. Whether the product is labeled sterile or sterile fluid path has some read on exactly what is done. But in essence, out to the end of the current shelf life, we would need to prove that the product remains integral. Of course, we also have to prove that the product works for its intended purpose, the intended purpose generally being to collect, store, and often transfer blood and blood components. And depending the product, then there's a number of guidance coming from AABB, FDA, or other sources that read on the types of studies that we need to do, both in vitro lab studies, sometimes also in vivo clinical work that ranges anything from primary indicators such as red cell hemolysis, platelet pH, platelet count, concentration, and the like, but might also include things like radiolabel recovery and survival. Again, all done as part of an initial product evaluation showing that it's suitable for its purpose. Very often these sets, even blood bags, are used in conjunction with systems. In the case of apheresis collection sets, also rather complex electromechanical systems that have a number of clamps, sealers, pressure sensors, optics, and the like. And of course, as a manufacturer, it's incumbent that we demonstrate the ability for the set to perform appropriately with all of those interfaces also over the shelf life of the product. At the same time, we have to demonstrate that the materials are safe to use in any given collection set. This is generally including biocompatibility and toxicology per ISO 10993, which I assume many of you are aware. This is also premised more and more on the identification and quantification of extractables and leachables compounds that also read into the overall safety assessments that we as manufacturers submit as part of our registrations. This is also more and more, not just with FDA, but also in other places of the world like MDR, becoming a requirement or has become a requirement to demonstrate over the shelf life of the product. And then lastly, many of these products contain compendial solutions, anticoagulants, blood processing, and or storage solutions. And in that case, we are also required to adhere to the ICH stability guidelines for drug substances. And this reads heavily then on our formulation limits, and when a product contains a solution, also reads heavily on the potential shelf life that the product is able to achieve, because at the end of the day, and at least under current requirements, we have to set and adhere then to those compendial limits. Okay, so that's a little bit about the, let's say, the considerations we face, regardless what shelf life we pick, and the data that we put behind defining a shelf life for a given product. If you could go to the next slide, please. What I want to highlight then are some of the key aspects that might limit the ability to extend the shelf life of such processing kits. Firstly, the material properties are not always static. And anyone that has any familiarity with plastics and plastic components know that these can and do change over time. The strength, elasticity, permeability, bonding, even visual aspects such as color, materials, maybe yellow with age, with light exposure, can potentially and generally do change over time. Again, this ultimately could degrade and affect the product integrity and performance. Again, our goal as manufacturers, following what I mentioned on the first slide, is to demonstrate that at least within the current shelf life, these properties do not significantly change to an extent that they result in a loss of performance. But it is true that if you go well beyond the current shelf life, then this would be a bit unknown and would be an area of consideration. We would need to potentially reassess product function, integrity, leachables, even blood product storage. So again, not to say those things are impossible, but it does represent a relative significant set of work that might need to be done in the case, and really depending the length of shelf life extension that was sought. Again, in regard to those products, and most do contain solutions, of course, no packaging or container is ultimately 100% impermeable. And this means water loss simply will occur over time. And again, as I mentioned, the current shelf life and the formulation limits that we define and adhere to ensure that we stay within those compendial bounds, if you will, over the course of the existing shelf life. Of course, if as you would go beyond the current shelf life, then those concentrations will continue to change. Perhaps pHs continue to shift. You will certainly, at a point, exceed many of the established limits, certainly compared to what we have in compendia or in our current registrations. As well, when that happens, the effect on storage of blood and blood components would need to be considered. Again, if you're going to collect in a much more highly concentrated anticoagulant or a more concentrated additive solution, then certainly we would have to assess if that has an effect on the resulting blood component storage. Again, it's hard to predict if it will, and that's not to say that some extension of shelf life might not be possible, but it would be a question of, how much degradation over what amount of time and what resulting impact it would have. So I think if you go to the last slide, and maybe I've touched on a few of these points, but I think these would be the important things to take up as a next step, and perhaps have some further discussion if there was a strong interest to continue looking at the extension of the expiration dates of some of these blood collection products. First discussion point, is again, have manufacturers really performed studies at time points beyond the existing shelf life? Again, I can only speak for Fresenius, I can't speak for others, but I suspect that that body of data is very limited, if at all. And I only say that to mean that we would be in a bit the domain of exploration, and that the extent of certain challenges to overcome would currently be unclear. How much does performance and quality taper off beyond the existing shelf life is something that would have to be assessed and understood probably before any decision could be taken. I think going back to the second point here, just to maybe reiterate what I called out on the first slide, is typically the validation of these products is quite costly and quite burdensome. Any of you in the that have been involved with some of the clinical trials that have supported original qualification of some of these products know the time and effort that goes into this. And again, if there, if extending the shelf life meant that entire body of work had to be repeated, then of course that would present potentially a burden on industry, as well as the clinical sites that we greatly appreciate and support, and do support us in gaining registrations. But we also know those capacities are limited, at least in most of the major markets that we operate. And then lastly, like I said, our products are currently designed and qualified to perform to a certain level within currently established limits for things like solution formulation, for the quality of the collected blood products. As we would go beyond the current shelf life, then they need to consider if those limits are still appropriate, and if they're required, could be then an overriding limiting factor, or in the interest of perhaps this extended shelf life, is there some exceptions or relaxing of some of those requirements under certain conditions, I think would have to be discussed, because we do know there will be a point you trend outside current limits, and then you either have to accept or not accept that. We also know that more and more there is a desire to see real-time aging to support the shelf life of products, but of course real-time means just that. If you have a product that is currently 3-year shelf life and you want to go to 4-year shelf life, you can start that study now. In 4 years, you have the data. I don't mean that to sound overly critical, but it's just a fact that these are very long-ranging studies, and it would just read on timing and expectation for when you might be able to have an extended shelf life, unless there were other ways to manage that with, say, accelerated aging. And then lastly, it's no secret that everyone in every industry deals with constant supply chain challenges more and more. Post-COVID, we have raw material suppliers going out of business, consolidating their portfolios. It's provoking across the industry a constant ongoing set of changes that we all deal with in terms of maintaining these products. Again, I think it warrants some discussion what type of maybe retest requirements would be, because I would also foresee that regardless of what initiative you would start today, changes will come over the coming years and maybe in the midst of such studies. And then if you're constantly in a redo restart loop, you never get to an end point. So again, those are some of the things that I think are worthy of discussion. And hopefully I've not made this sound too negative, but at the same time, it's also not a trivial topic. And I think we would be interested to, be a part of any follow-up to brainstorm or come up with ideas how this could, for the benefit of industry as a whole, for benefit of the blood collectors, do this in a meaningful but also efficient way. Okay, with that, I think that was my last slide, and I don't know if there's the intention to have any questions. Certainly open to it if there are. Otherwise, thank you for your time.
Thank you, Brian. Jed has a question.
Yeah, I may have missed it. EU wants to get rid of DEHP in bags. What's your national and international plan?
Are you speaking to Fresenius Kabi specifically, or industry as a whole? I guess the way I would answer it is we're obviously aware of those demands and needs. We have product development and long-range plans that aim to address those needs, and in regions where there have not been mandates, we're in discussion with our major customer groups to calibrate on interest and timing to look at the available materials and options as they become available.
Thank you. Ray?
Yes, first of all, thank you for being brave enough to come out here and address this topic with this group. Appreciate that. I guess one of the questions in my mind, obviously making changes is difficult, and perhaps appropriately so, because you have to go through those processes to assure that the products are safe and effective. So the question about reducing testing is a tricky one, obviously, if you're going to extend the shelf life. But I want to address maybe something that is unsaid here. I'm assuming that if there were economic advantage to the industry of having an extended shelf life, that investment would be worth making. And what I'm hearing is that it probably isn't. And so there appears to be a misalignment in the sense of it's a lot of work, that work would be an advantage to people who use the product, who store the product, in having it in cases where there may be shortages or there may be lack of supply for a variety of different reasons, as we've been discussing, everything from pandemics to hurricanes. But if that incentive isn't there because there's no advantage to industry to make the investment, to make the change, this is never going to happen. So my question is, do you think it's a matter of science? What I'm hearing is you're saying we don't know. But how was 3 years established as a shelf life? Did people try for 4 or 5 and didn't make it, or did they not try? Was that established based on science, or was that established based on business economics?
Well, thank you for your comment. I mean, there is obviously an economic aspect to this as well. But short answer is, in the case of the products containing solutions, which is the vast majority of them, at least within our portfolio, I can't speak to other manufacturers, that is based entirely on science, because the overriding requirements for the ICH stability guidelines tend to be the limiting factor, and in often cases cause the shelf life to be maybe shorter because of the solution than the rest of, say, the dry kit could possibly function. That's premised on, again, state-of-the-art and available containers and packaging material. And we always strive, and I can only speak to our approach, we always strive to deliver the longest possible shelf life, which is then within which allows us to stay within the limits and requirements as prescribed. In a case of a handful of other maybe dry products which don't have the solution consideration, then I would say it's a little bit more the historical norm that, depending the product, maybe a 3 or a 5 year shelf life was the norm. And as requirements to better support those shelf life, I mean, I've been in the business 30 years. I remember a time when you could apply a 5 year shelf life on a dry product, and there wasn't so much data behind that, right? It was just considered long enough, and maybe you had some very cursory aging studies. Again, that's vastly different in modern times in terms of the data that has had to be collected. In general, it was a matter of putting data behind then those existing shelf life. And unless we got a demand in a new product development for a significantly longer shelf life, then of course, feeling comfortable what the materials were able to perform, having that predicate knowledge, of course, it was a lower risk approach to stay within those typical shelf lives, which were, again, somewhere on the range of 3 to 5 years, depending the product. I would say now, looking forward, your point's very valid. Given the type of information that's required to support shelf life, it does become quite burdensome. And, it's hard to see from the manufacturer side a compelling benefit to make that investment in and of itself, right? I don't say that to say it shouldn't or maybe couldn't be done. And I think that's the domain of maybe some follow-up discussion to have. But in the case of the majority of the products, it really relates to the solution stability.
I'd like to explain that Brian was invited after discussions with the working group as we were developing the recommendations. How could we make stockpiles more efficient? And a clear answer was, if the outdates were longer, then it would be easier to maintain a stockpile. As to whether the benefit is worth it from what Brian has told us, well, that's an open question. But that is how this came about.
Quick
Yes,
question. For those products that contain the solutions, which are the rate limiting factor for expiration date, what's the average expiration date for those products? 1 year, 2 years?
Roughly 2 years. I can only speak to our own portfolio. We have blood bags that, depending the packaging and processing methods, range between 20 months to 36 months.
Okay.
I would say the majority are closer to the 20-month mark.
Are you able, Brian, to speak to your manufacturing capacity out of the Puerto Rico facility?
No, I would. Not in a direct way. I represent the product development side of the organization, and I think I might run the risk of misspeaking on behalf of my colleagues that are responsible for supply chain and production.
Oh, I can appreciate that. If you will pass along an interest, I have an interest to understand, being a new member to the committee, to understand better your manufacturing output capacity and the challenges that you face. Because just on the back of the envelope, I get a sense that the expiration date is satisfactory for the products to build and sustain a surge supply inventory, and have a rotational basis. The committee has talked about manufacturing stocks in multiple locations. It just seems like, to me, it could be a manufacturing issue today that could ultimately advance on to expiration date next year, but immediately it's manufacturing output.
Yeah, in the short term, it obviously would be, because if there is a surge capacity, I think you hit the nail on the head. Having a longer expiration date, but without an available pool of products or the ability to provide a bigger pool of products, being able to store a product 3 years versus 2 years doesn't help in the terms of, let's say, an immediate crisis. Could I ask who was speaking, though? Because the video on my screen is about 1 inch tall, and I can't really see any faces.
This is Lou Barnes. I'm the representative of American Association of Tissue Banks.
Right. Okay, Lou, thank you. All right. I just wanted to make sure. Yes, I can take a follow-up offline and try to engage with you at the appropriate parties to maybe further that discussion.
Any other questions from the room or online? If not, Brian, thanks again for doing this, especially with the timeline that was set. Thank you.
No problem. Thank you very much, all.
So that is the close of the presentations. I think we should take a rapid bio break. Perhaps if we could reassemble at 5 of in the room, we can begin discussing the recommendations.
Produced by the U.S. Department of Health and Human Services.